Hi, good morning, Dr. Wallace-Bain.
Okay, good morning, good morning, good morning, good morning, and welcome to another exciting CME session brought to you by your Department of Continuing Medical Education. This morning, I am so excited about the presentation that we have this morning, and I'm sure that you will be filled with information that you can use to do the best that you can for your patients. Before we begin, let us open in a word of prayer. Father God in heaven, we come before you this morning, thanking you so much for allowing us to see another day, allowing us to have another opportunity to learn, to share with each other. We pray that the information that we receive today will be useful in our daily practice and that patients may benefit from the knowledge received today. This I pray in Jesus' name, amen. So this morning, I am excited to present our speaker for today. Most of you may know her, but for those of you who may not, I will introduce her to you now. Dr. MADIHAH Hepburn joined the Summa Health at the end of 2021 as an attending neurointensivist after completion of fellowship at the Cleveland Clinic. Her clinical interests are in multimodal neuromonitoring, cerebral autoregulation, and medical education to improve the quality of care for the neurologically ill patient. As the first Bahamian neurointensivist, her passion for education extends to her home island, where she acts as an honorary faculty at the University of the West Indies School of Medicine. She volunteers her time to conduct neurology seminars and virtual lectures to the local internal medicine residency program and invited lectures at regional medical conferences. She aims to empower non-neurologists to care for patients with acute brain injury in a setting with limited access to specialized medical care. Dr. Hepburn hopes to continue her contributions to the improvement of neurological care in Akron, even though Ohio winters are much different from her home in the Bahamas. So this morning, please welcome our colleague and my very good friend, Dr. MADIHAH Hepburn, presenting on management of blood pressure in acute stroke. How low, how fast, and when? Dr. Hepburn?
Thank you very much for that very kind introduction, Dr. Wallace Bain. It's always good to be back home virtually, even though I would definitely prefer to be giving this lecture in person for many reasons. But today we're going to talk about management of blood pressure and acute ischemic stroke. And, I've given this lecture in multiple different iterations over the years. And I usually start off by kind of saying that, if you put 3 neurologists in a room and you ask them about blood pressure targets in acute stroke, you're going to get about 6 different answers. And hopefully, and, fortunately, actually, with the newest published guidelines in 2026, some of that variability, no pun intended, is going to be a bit reduced. So today, we're going to talk about an overview of stroke definitions, subtypes, and terminologies. And, in order to, go through the lecture, we have to make sure that we're speaking the same language in terms of definitions and subtypes. The lecture is really grounded in the pathophysiology of cerebral autoregulation and, and the concept of the ischemic penumbra in acute ischemic stroke. And then throughout this lecture, we're going to basically use several cases. So it's really a case-based review of, evidence-based blood pressure thresholds for patients with acute stroke during the hospitalization, and how do we work through deciding, how to manage these patients. This lecture is really, it's actually, it's not designed to take up the entire 60 minutes. So at the, it's going to be about 45 to 50 minutes. So at the end of the lecture, in addition to questions, if you have any particular like challenging patients or cases, with stroke, feel free to bring them at the end for discussion. And then finally, we're going to really highlight the key updates in the American Heart Association, American Stroke Association guidelines, which came out, I think in February or March of this year. That was the most recent iteration. Previously, the previous guideline had been 2021. And since, this, I work in the United States, but we, in the Bahamas, we can use guidelines from multiple different bodies. I'm also going to basically talk about how the AHA and American guidelines, like, align with the Canadian stroke guidelines for best practice, as well as the European Stroke Association guidelines. So, really, why should we care about strokes? Well, May is National Stroke Awareness Month. But, and in general, we care about strokes, every month of the year, not just May. But, strokes are common. There are, globally, this is from WHO, like 101 million people living with some form of stroke aftermath. And 1 in 4 persons over the age of 25 will experience stroke in their lifetime. And really what this means for us, especially, in an audience of all physicians, there are, especially those of us who take care of adult patients, at some point in time in our career, we will take care of a stroke patient. And on a more personal level, at some point in time in your lifetime, you will have a friend, a family member, a family member of a friend, of a colleague who will have a stroke, and that you might be called to treat. And strokes are common even in the United States. So, nearly 800,000 strokes per year, which kind of aligns with nearly 800,000 heart attacks per year. And, and not surprisingly, because both MI and stroke come from the same form of, are related to the same comorbidities. And, strokes are deadly. They are the 5th leading cause of death in the United States. And, where does that stack up for us in the Caribbean? So this graph comes from CARFA. And I hope you guys can see my mouse, but this green line at the very top, this is a cohort of CARFA data from 2019, a cohort, basically taking stats from 2000 to 2016, basically mortalities in the Caribbean. And this is English-speaking Caribbean and Dutch Caribbean. But you'll see that this green line right at the top represents, deaths related to cerebrovascular disease, which, not surprisingly, it's in the top, it's in the top 5 leading causes of death in the Caribbean, along with diabetes, ischemic heart disease, and hypertensive disease. And then where does that stack up in the Caribbean, by age and by gender? And this is, again, from the same CARFA report in 2019, where on the right-hand side, you'll see this graph, which is talking about the leading causes of death by age. And persons aged 70 years or over, you see that cerebrovascular disease mortality is at the top. And even more concerningly, women are even more likely to have mortality related to stroke or stroke-related complication at 16%. Even in the under 70-year age group, cerebrovascular disease mortality is number 2, and still with women outstripping men, as the more affected group by stroke mortality. And overall, that tells us that that strokes are deadly, and they're affecting us. And in general, strokes change the way people live. So it's not just about that they have a high mortality. It's the leading cause of adult disability worldwide. A patient that has a stroke, basically gets removed from the workforce, and the direct and indirect costs of stroke are $52.8 billion annually. And I would say, 10 or 15 years ago, like when I started neurology residency, we used to see persons with stroke in their 30s or 40s, and you'd start looking for really esoteric conditions, hypercoagulability or some form of paradoxical embolism. But more and more persons who are younger are being affected, their strokes are being caused by the same 10 modifiable risk factors in the same, that affect, persons of older age as well. That's your diabetes, your hypertension, your obesity, etc. So it's a medical emergency. One point, I kind of like to think about neurons in terms of a finite amount. Although we have so many as we're younger, but as you get older, you lose neurons, and that's just naturally. And so 1.9 million brain cells die for each minute a large vessel stroke goes untreated. So for each minute of ischemia time, your brains are just dying. Sometimes when I'm a stroke team, I just think of just neurons just crying. And stroke treatments are time sensitive, and they depend upon getting the patient quickly to some form of stroke center. And overall, we know that the faster we treat a stroke, the more likely that these patients are going to have better outcomes. Patients treated within 60 minutes of the onset of symptoms. So if you have stroke symptoms and you get treated, and we talk about treatment with acute reperfusion therapy, you have better outcomes in terms of decrease in hospital mortality and decreased long-term disability. And management of stroke is a continuum of care. I recognize that I work at one point of the continuum. I'm a neurointensivist, so I work all inpatient stroke neurology. But in general, the most critical management of stroke patients starts before even the hospitalization. And our primary care physician colleagues, they play, a critical role, I would say the most critical role in reducing those comorbidities that lead to stroke risk. And they continue the management of all of the medical comorbidities of stroke patients post-hospital, post-rehab. I mean, I dream of a day that I would be put, quote, out of business because we've reduced, medical comorbidities. And so strokes are much, much less. And so in terms of types of stroke, this lecture is really focused on blood pressure management in acute ischemic stroke, which is caused by a blockage to a blood vessel, either by some form of thrombosis or embolism, either from a blood clot or rupture of a fatty plaque. The other subset, the 20% of hemorrhagic strokes, really blood pressure management in hemorrhagic stroke it literally is a lecture by itself. So that's definitely a part two, because that's a whole different set of guidelines and priorities. Throughout the cases, you'll hear me reference back not only to the description of the neurological exam, but to something called the NIHSS stroke scale, which is a 15-point neurological examination scale, which is used to evaluate the effect of stroke symptoms. Basically, it has different domains. We're giving grades for degree of aphasia, motor weakness, sensory loss, etc. And really, what I kind of put it, it's a clinical tool. It's simple, it's validated, it's reliable, as reproducible, as used globally across hospitals and stroke centers. And it's a measure of severity as well as outcomes. And it's a common language. So for example, if I get a call from my colleague in the ER and they say, hey, I'm in triage and I have this patient with stroke symptoms and the NIH is 3, then I know that that's going to be a minor stroke. And so that patient is going to, if they're not a candidate for like thrombolytics, that patient is going to be stable to go to the floor. But if they call me and say, hey, this patient just rolled into triage and they have an NIH of 20, then I'm anticipating that this patient is a candidate for acute stroke interventions or may need the ICU, et cetera, because they're at high risk of deterioration. So we'll reference back to as well as stroke subtypes throughout this lecture. And in general, there's a classification called the TOAST classification where they basically put, all strokes into ischemic strokes into 5 big buckets. When we can't figure out what it is, we call it cryptogenic. And the most common ones are going to be the first 3 that you see here. So that's going to be a large artery atherosclerotic disease. So that's things like your carotid stenosis. This is an angiogram picture of a patient with a carotid lesion that ended up having a distal embolism, atheroembolism, starting, that included the left MCA. And then you basically see that we end up doing a thrombectomy, recanalize the MCA as well as, sorry, this is the right MCA, recanalize the MCA as well as place a stent later on for those patients. And those patients tend to have large strokes because they're basically clotting out large vessels with that, there's a large territory of brain, as well as your proximal embolism, your cardioembolic strokes. So these are going to be strokes in multiple vascular territories. For example, like AFib, arch of the aorta, embolism, PFO, et cetera. And then, the very common, your small vessel disease or your lacuna stroke, which is caused by hardening and arterial sclerosis of the very small deep vessels, which give you these small little tiny, what we call lacunes, which is pretty much a stroke that's less than a centimeter. And those are going to be your very typical diabetes, hypertension, et cetera. And of course, the rare stroke causes, which we're not going to discuss today. In general, persons who have, there are very few people these days that just have one stroke mechanism. People tend to have overlapping stroke mechanism, of which, so by basically looking at the patient characteristics, their comorbidities, as well as the pattern of stroke on imaging, not even the acute stroke, not only the acute stroke. So for example, this patient has an acute right MCA stroke, and that's how they presented. But once we did the MRI, we found that they also had evidence of older left MCA strokes that they were asymptomatic from. In fact, actually, the patient didn't even realize he'd had a stroke in the last year. And this patient went on to be diagnosed with paroxysmal atrial fibrillation, which was the cause of these multivessel strokes. And again, you'll hear me talk about the large vessel occlusion stroke or the LVO stroke, which are caused by a thrombus, in the large vessel in the circle of Willis. And we're talking about like the ACA, the middle cerebral artery, the internal carotid artery, basal artery, and the posterior circulation. And these really supply a very large area of the brain, and if left untreated, they cause the most severe damage. I think large vessel occlusion strokes account for about 10% of all strokes, but they account for 90% of all mortality and morbidity because they're so devastating, because they affect such a large area, a large territory of cortex. So when we talk about how do we diagnose it, so, there's, a combination of acute stroke imaging as well as clinical exam. So in general, I mean, our workhorse is going to be your CT angiography of your head and neck. So a patient who's coming in as an acute stroke alert, they'll get, as a package, they'll get the non-con CT head, which by guidelines are done within 20 minutes of arrival, if you have acute stroke symptoms. And a CT angiography head and neck to look at the vessels intracranially and extracranially. You can also take a look at the vessels with an MR, with the MRA head or neck, but of course that's not going to be readily available or practical for an emergency setting. And so sometimes, might ask, okay, well, if you don't have access to CT angiography, how can you make a determination that this patient may be having a large stroke or having a large territory of stroke? And one way we do it, and because so where I work, we're basically a hub, so we're called a comprehensive stroke center. So we basically do all of the stroke interventions, but we get actually patients from very rural areas around here in Ohio. And some of those areas that we're getting people like sent to us, they don't have access to a CT angiography. They may only have an access to a non-con CT head. And like they're sometimes just a freestanding ER in a rural hospital with like one ER doc, and just a non-con. You have access to X-ray and a CT scanner, and that's it. And so, one way you can say, hey, whether or not this patient has a large vessel occlusion stroke or a stroke that's potentially going to be very large and, have a high risk of deterioration is using something called the aspect score. So that's basically, it was created in Alberta in the 1990s. But basically what it is, it's a scoring for your non-contrast CT head. So you'll take basically cuts at the level of the basal ganglia, which is seen here, and they're regions. So there are 10 total regions with the basal ganglia. And like, for example, C is the caudate, IC is the internal capsule lentiform, and these are your M1, M2, M3. These are your branches of the middle cerebral artery. But essentially, you look at the CAT scan, and we basically do this like right in the scanner. You look at the CAT scan, you say, hey, is there any loss of gray-white matter differentiation? This is an extreme example, but so for example, if I just said, hey, there's a little loss of gray-white differentiation in the caudate and the lentiform nucleus, I'll knock off a point for each. If there's no loss of gray-white, like the score is 10, that's perfect. But each time you have a loss of gray-white, you knock off a point. And so that's called your aspect. So for example, this is a very poor aspect. This person basically has an aspect of 0 because there's stroke in every one of these areas. But sometimes you have more subtle ones, and we'll kind of reference back to the aspects throughout our cases throughout the lecture. But in general, if you have an aspects greater or equal to 6, you're looking at a smaller core infarct. And if you're an aspects less than or equal to 5, you're looking at a very large stroke core, and the higher risk of disability, mortality, and neurological deterioration in hospital. How else can we decide, is this patient having a large stroke or not? We can also use some pre-hospital tools. So we partner with our EMS and our paramedics. And so they're trained that if they find a patient with a focal weakness, and then it's called the VAN scale, focal weakness plus, they examine, they find a visual deficit, there's aphasia, there's neglect. They're actually trained to skip. So they would not take that patient. So they call it as VAN positive, which really has 100% sensitivity and 90% specificity for detecting an LVO type of stroke, which is going to be your more severe kind of stroke. They're trained to actually skip the nearest ER. So if they wouldn't go to the ER that within 10 minutes of them, they'd go to the one that's further, that is a stroke center, to maximize being able to treat these patients. And so if you have aphasia, and so just clinically, if you have a patient presenting with aphasia and neglect, and throw in some gaze deviation, even without weakness, those are really highly sensitive markers for an LVO. And then if you combine those, a person with new onset aphasia, neglect, or inattention, and you combine that with hemiparesis, that really increases your sensitivity of detecting a potentially very large stroke, even if you can't see it on a non-contrast CT head as yet. So we talk about the cortical signs. So these are patients, as we talk about aphasia, neglect, gaze preference, gaze deviation. That's going to be an LVO stroke until proven otherwise. And so that's why an NIH greater than 6 is going to be a probable LVO, and an NIH greater than 10 is very highly likely. Now, of course, are there cases where you have gaze deviation, neglect, and hemiparesis, and it's not a stroke? Yes, but in general, it's going to be some form of stroke until proven otherwise. Your lacuna strokes are going to be your smaller subcortical signs. They take up a much, as you can see, a much smaller territory, these kind of very small areas where they tend to have dysarthria. They tend not to be drowsy. And they tend to have very pure motor or pure sensory deficits. For what we have available to us is also just in terms of just the spectrum of imaging. We'll also talk about CT perfusion, which is an imaging technique where we basically calculate the cerebral blood flow volume and time to transit from, for persons with a stroke. And you really want to be able to, it's a decision-making tool to really decide whether or not you have core infarct and penumbra and what is salvageable. And so, for example, you'll see this little scans, we see the little purple areas. These are areas that's already infarcted. But this area of green, this is going to be your ischemic penumbra, which is potentially salvageable if you can restore blood flow. And like I said, we restore blood flow in 2 ways. Either the patient is a candidate for IV thrombolysis, if they meet the time window parameters, or they are, they have a physical clot like we can see here, and you can basically do a procedure called a thrombectomy, where you just drag out the clot and immediately restore blood flow, as you can see on these angiogram images. And so in addition to timely recanalization, the principle of stroke care is you have to optimize collateral flow, because like I said, you have basically the brain is going to try to rush in to basically support that penumbra area. And we have to basically medically management in terms of fluids, blood pressure, and hemodynamic targets. And the whole goal is to minimize secondary injury from the cerebral edema, hemorrhagic transformation, et cetera. So we'll start with a case. So case number 1 is a 68-year-old male with uncontrolled hypertension who was found by his family in the afternoon around 4 p.m. He was found nonverbal, so basically had global aphasia, had complete right hemiplegia. It was what we call a complete left MCA syndrome. And his last known well was when his wife left for work in the morning at 5 a.m. He was a pre-hospital stroke activation. His NIH was 27, and he was hypertensive on arrival, as you can see here. Just going A to B to C to D, and the A to B is the non-contrast CT head we did immediately. You can see there is this very hyperdense thrombus. So that's your hyperdense sign in your left MCA that basically says, hey, even without contrast, I can see a clot sitting in this patient's left middle cerebral artery. And then he had a loss of gray-white matter differentiation all throughout the left MCA, and again, aspects of 5. So without knowing anything more, just by seeing this, I know that this patient has a high chance of deterioration. We did a CTA, and the yellow arrows show that he actually has a very long thrombus, a clot. His left IC was completely occluded from the cervical portion, intracranially through the petrous segment, and basically there was no flow through his left MCA completely. And then we did a CT perfusion where you can actually see the core infarct, and there's still a large penumbra area. Now, it was too late to salvage him in terms of being able to take out the clot. So we had to basically use medical management and blood pressure management in order to maintain his collaterals and support that penumbra. Because if your collaterals fail, all of this green area is going to convert to the pink area, which is going to add to your morbidity. And so we basically created a target. We used vasopressors, initially levofed, norepinephrine to basically, maintain his blood pressure on the high side, systolics in the 170, 180s. His exam improved and he got transferred. And we of course managed his cerebral edema medically with hyperosmolar therapy. And then he was transferred to the stroke floor on day 5 post-stroke, and actually doing quite well. On day 6, his blood pressure was, day 6, we're basically trying to get ready now to go to rehab. And, this is when sometimes you have a conflict between what you need for rehab and what the patient needs individually for their brain, health. And on day 6, he was hypertensive above 180. And so he was given multiple doses of IV hydralazine. I started on 2 antihypertensive medications, losartan and amlodipine. And overnight, he had neurological worsening. And you can actually see This is the repeat CAT scan where you can see kind of left to right. You can see that there's a much larger stroke that has now evolved and is actually now extended his infarct into the anterior cerebral artery along with the MCA, and he has midline shift and compression. So he had he dropped his level of consciousness, developed anisocoria, had signs of uncal herniation, required intubation, and was taken for a decompressive hemicraniectomy. You can see on the side here. He still actually did relatively okay. I mean, he survived, and he's actually was discharged to acute rehab about 2 weeks later. So when we talk about, so that's an example of a case with a with a large stroke, an occluded vessel, and you have to basically understand the cerebral autoregulation to determine how you're going to manage the blood pressure in the situation. And cerebral autoregulation is really your capacity of your cerebral circulation to adjust to maintain the constant cerebral blood flow despite changes in systemic blood pressure. And it's a dynamic process and is really affected by multiple things. But more importantly, when you have an acute ischemic stroke, you have failure of a normal autoregulation. And so, sometimes your vessels are already maximally vasodilated in order to support the penumbra. And so basically, if you basically change the blood pressure too quickly, and so rapid shifts, like for example, you overtreat the blood pressure, essentially those neurons within that ischemic penumbra are more vulnerable. And then basically with drops in that blood pressure, the penumbra can convert to a much larger stroke. And you also have to consider what are the underlying characteristics. Persons who are, our blood flow curve when we have normal, when we're just walking around normal tensive is pretty much here where we kind of, we auto-regulate between 60 to 120. But if you're chronically hypertensive, you have a right shift. And, I would say the majority of our patients that we take care of with acute stroke are, have hypertension as a comorbidity. And you have to understand that their autoregulation is already shifted to the right. So they maintain their cerebral blood flow at a higher mean arterial pressure to begin with. And then add to the fact that when patients come in with an acute stroke, they do have higher blood pressure levels on admission compared to persons who present with non-stroke. And that's because there is an acute hypertensive response to just having the stroke itself, where we basically see, nearly 80% of patients that present with stroke, they're presenting blood pressure systolic is above 140. And, so which means that we already know we're autoregulating differently. In general, when we say, okay, which clinical subtypes present with a higher blood pressure, those are going to be, for example, this is taken from a cohort of stroke patients on admission, but persons who have acute, like a lacunar syndrome, so the small vessel disease, they tend to present with a higher blood pressure. Older stroke patients tend to present with a higher blood pressure as well. And so that acute hypertension is a physiologic compensator mechanism to preserve your penumbra perfusion and support your collateral circulation. So for example, in this picture, you'll see this dark orange center. So that's going to be your core infarct, where you have this focal reduction of blood flow because you have the occluded vessel. And then surrounding it in the kind of more orange is going to be your area of decreased, the area of penumbra where vessels are going to be, your collaterals are going to maximally vasodilate to try to support this area. And then out here's your rim of oligemia, which is basically just reduced flow. But again, it's not as severe as the internal. In general, the fate of your penumbra really depends upon your collaterals. And your collaterals are basically, I call it, the areas of your blood flow that ride to the rescue once you have an acute occlusion or basically an occlusion or thrombosis of a vessel. We have some just large primary collateral circulation. That's your standard circle of Willis, your PCOMs and your ACOMs. Those are going to be your main primary collaterals. But we have a secondary collateral system, one that either forms slowly over time. And so basically there's going to be kind of between your leptomeningeal anastomosis, so between your middle cerebral artery and the leptomeningeal arteries in that area, there's going to be collateralization. And there's also going to be, between like the MC and the PCA, these dural branches and basal branches. And, it's interesting because I think collateral circulation is really interesting because you almost don't know what you have until you get a stroke. And so there are some persons who maybe they would They were forming something slowly over time. They have this ischemic conditioning, and so they just form more collaterals naturally. So when they have a stroke, they fall back on these great collaterals and they do really well. But then the other patients, you get an acute stroke, and all of a sudden your brain actually decides to send no collaterals to the rescue. And those patients, they can be fated to have quite a large stroke. Going to case number 2. So this is a 49-year-old male patient with hypertension who presented to the ER with 2 days of fluctuating symptoms. And although he had 2 days of symptoms, when we talked to him, he actually probably had more like 3 to 4 days of just off and on symptoms, where he would basically get left facial weakness, left hemiparesis, dysarthria, would stay for a few hours, then completely go away. And then finally, on the day that he came into the hospital, like the symptoms, stayed, for more than 24 hours. But, even when he presented to us, we saw him, he had an NH of 2. So actually, very mild symptoms. And he had a blood pressure, this was his blood pressure, 140/98. So not super high. But, so the question is, what kind of stroke does he have? We do a non-contrast CT head. It's not going to come through so well in the, across Zoom, but trust me, where the red arrow is, there's loss of gray-white matter differentiation in this kind of frontal parietal junction. So that's why he had very subtle symptoms. So he had aspects of 9, so great aspects. And then, he has this occlusion. We do a CTA. He has an occlusion here. And this is a distal M2 occlusion on the right side. And then in addition to that, we did the neck. And this blue arrow shows essentially a thrombus that's essentially sitting right at his right carotid bulb. So he basically had this carotid lesion that been, this is what we call a tandem occlusion. He had this carotid lesion that had been forming slowly over time. And finally, it was shaggy plaque and just breaks off, and it causes this distal M2 occlusion, this distal right M2 occlusion. It's in general, so the question is, what do we do with this? I mean, he sounds like he has pretty mild symptoms. He's been having symptoms for several days. And, so, potentially, this could be the limitation of his stroke. But, the fact that he has all of these, these large vessels are involved, that's concerning. And, he's out of the window. We can't give him thrombolytics. And this distal right M2 clot is too, you just can't get at it with a catheter. It's too small. And then so we use actually a CT perfusion to risk stratify him. And we actually found that he really didn't have any core infarct, but he had like over 100 cc area of penumbra. And so this is coming from that carotid lesion. And so the problem is that if you're not careful with these patients, you can actually, their collaterals, he's living on collateralization right now. And if you're not careful with both augmenting the blood pressure and preventing, hypotension, these patients actually can just collapse their collaterals and he'll go on to have a large stroke. So we actually admitted him to the ICU. We augmented his blood pressure with norepinephrine. We took essentially, as what's kind of standard, you take whatever the baseline blood pressure is, and you basically augmented 20 millimeters of mercury above it. So we basically aim to get his blood pressure above like to 160, 160 to 170. And as we actually raised his blood pressure, his symptoms went away completely. And we started him on heparin infusion because this actually was a free-floating thrombus. And then we actually did an MRI about 36 hours later, and his symptoms had completely resolved by then. And he was just left with this very small stroke right here in the insular cortex. And he had full recovery. And then because he was a high-risk lesion, he had a right carotid endarterectomy during the same hospitalization for treatment of the symptomatic carotid stenosis. So overall, what we know about blood pressure and stroke is that, it's a bit of a pendulum that, blood pressure, increased blood pressure and low blood pressure, can affect stroke outcomes. If the blood pressure is too low, as in the patient, this reduces tissue perfusion and it extends your infarct size. But it's always been a question of, how high do you leave it for? Because we do know that if you leave it for too high, these patients are at risk for complications from reperfusion, like hemorrhagic transformation, cerebral edema, et cetera. And so there has to be a balance in terms of, where do we go? overall, I would say, there definitely is this U-shaped curve, like too low blood pressure is not good and too high blood pressure is not good. And, we're probably coming to a time, hopefully in the next 10 to 15 years, where we're going to be able to individualize blood pressure targets to patients, because it really does depend upon not only the type of stroke they have, what is the underlying vessel status, what is the underlying comorbidities, like chronic hypertensive or not, heart failure or not. So we may be coming to a time, hopefully in the next, hopefully in my lifetime, where we basically say, hey, we can find what is your sweet spot for your blood pressure after you have a stroke and target your therapy for that. But until then, we have to have until that we have that data, we have to have guidelines. And now we actually have more. When I did this talk about 5 years ago, I really had what question mark was the guidance from the guidelines. And now we actually have more guidance in this new iteration that came out in 2026. And overall, the management of blood pressure and acute stroke really aligns with, are they a candidate for reperfusion therapy or not? And sometimes they're not a candidate for reperfusion therapy, one, because they're coming outside the time window, or, they don't qualify because the stroke is not large enough. And so what targets you choose really depends upon, hey, what do you need to do for the patient? Are we taking them to IV, giving them IV thrombolysis? Are we taking them thrombectomy? Or are we going down the medical management route because the stroke, because they've come out too late outside of the window time? And again, you go how low and how fast to go. What has not changed is that, if you are going to treat the patient, as in you're going to go take them for thrombolysis, you still are going to, if you're going to give them IV thrombolysis, if their blood pressure is above 185 systolic and 110 diastolic, you have to treat that in the acute phase in order to give them the thrombolysis. But what about those patients that are not going for, thrombolysis or thrombectomy? So we'll talk about that here in case number 3. So this is a 70-year-old female with hypertension, uncontrolled diabetes. When she came in, her A1C was actually like 12.7%, came in with like a glucose in the 400s, 500s. And she presented with more than 24 hours of symptoms, dysarthria, dysphagia. She had left hemiparesis and ataxia. She wasn't a candidate for stroke intervention, so she was admitted to just the regular medicine floor. Her blood pressure on admission was 210 over 98, and she had an initial NIH of 4, which is still mild, left arm, left leg. And if I remember correctly, this woman was still able to ambulate even with the weakness in the left side of the ataxia, very mild dysarthria. In the first 24 hours after admission, so this is basically, she still would have been in the first 48 hours of onset of symptoms. Her blood pressure systolic was about 210 to 215 consistently, and it would actually lowered rapidly with IV antihypertensive to a systolic of 140, so which was about a greater than 30% reduction in that first 24 hours of admission. And she had neurological worsening. Her NIH went from 4 to 10. We repeated this was her in the red up top. This was the initial ischemic stroke that she had. You can see there's a right pontine stroke. And then once she had the neurological worsening after treatment of blood pressure, we actually found out, worsening exam, we re-imaged her, and she had the extension of the acute right pontine infarct. She still went to rehab, but her recovery was definitely more prolonged than what it would have been if she had the initial, if she really only. I created a table here that has the American Heart Association, Canadian Best Practice, and European Stroke Organization. And so in general, for patients who are not going for reperfusion therapy, so they're basically going for medical management, normally you should, correct hypotension, hypovolemia, which is, there's, saline, with, IV fluids, et cetera. But essentially, if these patients are not a candidate for acute therapies, you really should not treat them if their blood pressure is, up to the point of 220 over 120, 220 systolic over 120 diastolic. And so really, if they're over 220 or 120, then you can, these are the patients are maybe old, there's a patient who coming with extremely high blood pressure, 230, 240 systolic, then those are the only ones you really should treat. But if you do decide to treat them in that acute period, you really should lower very cautiously, and really only by about no more than 15% in 24 hours. the guidelines before this had said maybe 25%, and there was still a lot of like iffiness. But now in 2026, there's basically say if you're going to treat them, you really should treat it only if it's above this target, 220 over 120, and you should really not lower it more than by 15%. The Canadian best practice guidelines basically say about the same thing, 50%, and so does the European Stroke Organization. So for patients for patients who have a blood pressure less than 220 or 120, there really is no benefit to initiating or even reinitiating their antihypertensives in the first 48 to 72 hours of onset of symptoms. So i.e., if you're admitting them, you really should not be, there's really not an indication to restart their oral antihypertensive medications. It has not been shown to have any more benefit in terms of stroke recovery and does expose them to more harm. Now, of course, there are extenuating medical conditions that require more rapid BP lowering. That's something that you consider on a case-by-case basis. So, for example, a patient with a stroke who's also having an MI, like if you're having a STEMI, you really do not want your blood pressure to be above 220, or aortic dissection, or they come in, or they're developing flash pulmonary edema from diastolic dysfunction. So the question is, and you really have to consider that there are also going to be a subset of patients based upon the type of stroke that they have, that even after 72 hours, they still may be more prone to stroke extension. So I would say 72 hours is kind of the average. But for example, so this was a study where they looked at the different stroke subtypes. So they looked at your large aortic atherosclerotic disease strokes. And so those are your patients with like basically large vessel occlusion, your carotid stenosis, your MCA stenosis, things like that. Those patients are at a higher risk of death or dependency with earlier blood pressure control. And so they actually more benefited from more kind of a more liberalized blood pressure target, essentially. But overall, it's a case-by-case basis. And you have to consider the timing for the patient presentation relative to the symptom onset. So for example, a patient with a lacunar stroke who comes in after 5 days of symptoms and their blood pressure is 210, there's really not an issue to restart their antihypertensive and get control. You still should, I would say, start low and go slow. But if you already had 5 days of symptoms, that danger zone is already over, as compared to if they came in, within 24 hours of symptoms, then you're basically up to 72 hours, you're still at risk for stroke extension, especially with aggressive blood pressure management. This practice pearls is kind of like I said, these are kind of rules I live by. I would say overall I go slow and monitor for neurological deterioration, still with the same 15% of the baseline systolic. I typically avoid this is not iterated in the guidelines, but I do avoid diuretics overall, because acute stroke patients are more prone to stroke progression with dehydration, hypovolemia, sodium shifts. All right. And so our last case is a 69-year-old right-handed female with hypertension, smoking, obstructive sleep apnea, who developed, while she was actually grocery shopping, right hemiparesis, left gaze deviation, global aphasia. She was brought in by EMS. Her initial NIH was 30, which is extraordinarily high. She was hypertensive, 212 over 106. She had a great aspects, because essentially she'd had less than 30 minutes of symptoms by the time she arrived to us. She had an acute cutoff in the left MCA, acute occlusion, and she had some small area of core infarct, but really a large area of penumbra that was potentially salvageable. So she was a candidate for both thrombolysis and thrombectomy. But her blood pressure
We're
was
supposed to be there already.
but
Just
her
God,
blood
I understand
pressure.
we could give him it.
Hi, do you mind muting yourself?
We have the meeting.
Yeah. The blood pressure was 212 over 106. We intubated her for airway protection. And before we could even give her thrombolysis, we had to reduce her blood pressure to 185 over 115. Sorry, that's actually an error. That should be 110. And so we used nicardipine, we had labetalol, and then used nicardipine infusion to do that smoothly. She was taken for mechanical thrombectomy, and you can actually see here, this is like the tip of the catheter. There's no flow going intracranially through that left MCA. And then essentially we removed the clot, and this is the clot down here. It's about a 4-centimeter clot. We basically dragged out that entire clot and then recanalized her left MCA. And then for the next 24 hours, following the procedure, her blood pressure was not lowered any further than systolic of 180, and that's per guidelines. She went from an NH of 30 to 15 to within the next day, or with the next 48 hours, 72 hours to 9, and she was actually discharged to acute rehab, and then went home. And then this is basically the residual stroke that she had. And I usually like to, especially with families, usually show them like what the stroke could have been, this entire hemisphere, and then what we really ended up with. She had excellent recovery. And so, the last word on the guideline management is that before reperfusion, if you need to lower the blood pressure for thrombolysis, you really should lower it to less than 185 over 110, but you really don't need to lower it any further than that. And then maintain that, and then essentially after the procedure, maintain that less than 180 in general. But there used to be a lot of practice where we used to basically intensively lower the after thrombectomy to less than 140 because there was such a concern for reperfusion injury. However, there actually, has now been, which is why the guidelines came out, a large, more robust evidence that shows actually that less than 140 in these cases post thrombectomy is actually has a signal to harm. And what we really should do is basically just leave it at less than 180, especially for the next 48 to 72 hours, 48, especially in that first 24 to 48 hours. All right. And then a very brief word on outpatient blood pressure management. That comes from the outpatient management guidelines in 2021 for stroke prevention. And essentially, if you're going into the office, you're basically going for a person with hypertension who had a stroke or TIA, and usually going for a systolic blood pressure less than 130 over 80. I would say in patients who have acute stroke, I usually don't aim for less than 130 over 80 in their first office visit. And when I say I mean my colleagues, because I don't see patients after the hospital. But in general, once they're about 30 days, especially for the very large strokes, when they're about 30 days out, you really should go for your control of blood pressure. Smaller strokes, you can start earlier. So overall, I think this is kind of the bottom line. In the acute phase of presentation, especially if the patient is not going for any kind of reperfusion, you let it ride. I would say let it ride up to 220 over 120. If the blood pressure is consistently over 220 over 120, then this is when you're basically going to aim for no more than a 15% reduction of systolic in the first 24 hours. Patients, if they're going to be a candidate for EVT or IVT, you're going to lower to less than 185 systolic over 110 before thrombolysis. And then once you're successful, either with the endovascular therapy or IV thrombolysis, the recommendation is not to aggressively lower the blood pressure. So really avoid low blood pressures, lowering less than 140. And always keep in mind that you have to individualize to the patient that you have in front of you. So I'm actually going to stop here. This is my email. If you have any questions, you can always email me. But I think we have about 10 minutes for questions.
Thank you so much, Dr. Hepburn. That was indeed a very comprehensive presentation. You provided a wealth of knowledge, and I am sure our fellow colleagues are very excited to ask questions and or make comments. But while they are getting ready to do that, I would like to remind everyone to please ensure that you have your name listed as the name that you are registered in at the Bahamas Medical Council. We also ask that you be sure to complete the feedback for this presentation. It will be placed in the chat. Okay, I see we have a raised hand and a few comments in the chat section. I would allow at this time, Dr. LaVille, you can go ahead and unmute and ask your question.
Hello, good morning, Dr. Hepburn. Thank you very much for this really enlightening talk. And congratulations on the work that you're doing. I was just wondering, family medicine, does this affect how the hypertensive emergency with neurological symptoms is treated, is managed?
Yeah, that's a great question. I would say, in general, especially if you have focal symptoms, so you have a hypertensive emergency in patients with focal sensory changes or, focal weakness, especially, like you really can't exclude that they're not having a, true acute ischemic stroke or TIA. So I would say in general, I typically still for the hypertensive emergency still go by the 15% reduction in the first 24 hours, unless the patient is developing some other sign of like worsening organ system. So for example, if they're also having, active chest pain and they have ST elevate, ST changes, those patients you may want to go, a little bit faster, but usually still no more than 20 to 25% in that first 24 hours. And, you also have to be cautious, even if they don't have focality to the exam. So for example, they come in with blurred vision and, and kind of encephalopathy. Those patients, they chronically live at a very high blood pressure. So if you drop them, I still usually don't go more than 20% even on those patients, because their autoregulation is so impaired that if you drop them too fast, then they get rebound cerebral edema, and they can have, essentially neurological worsening.
Thank you.
Okay, thank you for that. We have a few comments inside the chat. Thank you for this super informative presentation, Dr. Hepburn. And another comment that says, excellent presentation. It was an excellent presentation indeed. It's very interesting that you mentioned just how we're seeing individuals presenting at a younger age with a stroke. It's so unfortunate. And we're definitely seeing it in primary care. So it highlights the importance of primary care. And hopefully we can all get on board to ensure that we do our part in primary care.
When we started med school, Dr. Wallace, you think that 50s, sounded super old. Now, as we get old, now as we are approaching our 50s, I still consider 50 young as young people.
Absolutely.
But yeah, in general, it's very rare that I have a patient who's cryptogenic, who in their 40s to 50s, who truly don't have, hypertension, diabetes, hyperlipidemia, sleep apnea and obesity. And it really is becoming, a problem,
We will continue the fight on our end. We have a question from Ms. Newbold. As an outpatient physiotherapist at a satellite facility, can you advise on communication recommendations for referred patients regarding BPHR protocols?
Actually, to answer that question, I kind of have to ask Ms. Newbold, in terms of, are you talking about seeing a patient with a stroke like in the very acute phase? For example, they just finished the hospitalization, or we're talking about a patient who's had a previous stroke and now you're seeing them more, a few months later for spasticity. Oh, both. Okay, no problem. Yeah, I would say in general, it really depends upon the size of the stroke. And sometimes, size of stroke you can estimate by essentially what's the degree of their neurological deficits. But I would say in general, less than 180, I tend to, if they're on the, let's say I would call it like a non-ICU stroke patient, so there are stroke patients on the floor, they're going to go to rehab or even outpatient rehab. In general, once they're stable, I would have their blood pressure to be less than 160 in the next week after that first, in the next week after the stroke. And then within about 14 to under 21 days, they could be basically normalized with the outpatient regimen. If we're talking about a patient who has very severe deficits where, very dense hemiplegia, that the stroke is large, or they had like carotid stenosis or something else underlying, those patients, it's more like, I would say more like you're not gonna really hit normal, which is less than 130, in the first 21 to 30 days. You're going to be a little bit more gentle. But I think like the in-between is going to be a systolic of less than 160, especially in that very acute phase. And of course, if you're, if as they're, going through their physio session and you're seeing that they're very refractory, they're going from 160 systolic to 190s, 200s, that's a patient with really impaired autoregulation. And so you may either have to scale back the intensity of their therapy or basically, work with their outpatient primary care to, to get improved blood pressure parameters, blood pressure control.
Thank you. From Dr. Turnquist, good morning. I enjoyed your presentation. Not sure if you covered this already, but in a space where there is no interventional neurovascular specialist, what would be your indication to refer to neurosurgery?
Yeah, that's an excellent question, because if you, in general, if you cannot recanalize the vessels, those patients are often fated to have a large stroke. You can only do so much with hyperosmolar and blood pressure management, things like that. Like we call it blood pressure augmentation. So I would say in acute ischemic strokes, if you have, so for example, that first case where you see a large infarct that is, we're talking about, it's called malignant MCA edema, and their peak edema is going to be in the first 4 to 5 days. So you're going to watch them real careful for the first, especially those first 4 to 5 days, with, serial neurological exam, basically management, you're going to basically push the, hypertonic saline or mannitol. But in general, if those patients are developing basically a change in their neurological exam, or if you already have a CAT scan that shows greater than 2/3 of that hemisphere is already affected with midline shift, and in all of those decompressive hemicraniectomy trials, though the degree of shift they used was 0.7, was basically 7 millimeters of the septum pellucidum. So basically, if you have essentially somewhere between 5 to 7 millimeters of midline shift with already a large anterior circulation strokes with going frontal temporal parietal, midline shift, those patients, especially if they're under the age of 60, you're not going to be able to reverse their fate with hyperosmolar management. My patient in that first case, we were able to, because he actually was much older, so he had more atrophy. But once you're basically under 60 and you already have what we call a full brain, and you already see that there's loss of there's that what we call low aspects, you have stroke evolving in that that frontal temporal parietal region, already starting to have midline shift. Those are the patients that I would call my neurosurgeon upfront early to do a decompressive hemicraniectomy. Because the decompressive hemicraniectomy is not just life-saving, but it gives them at least the chance for potential recovery. I don't know if that answers your question. I don't know if there's any neurosurgeons on the call. So the answer is call them early. Because there's only so much you can reverse with, I'm a neurointensivist, so I can't do surgery. So there's only so much you can get out of medical management. You can't really escape the fact that the skull is fixed and you're going to swell outside the skull. Yeah.
Okay, yes, she says, thank you. So that did answer her question. That was helpful. And also Ms. Newbold Center, thank you as well for responding to her question. We have another question. Good morning. How do we approach a patient on a family island where we can't go for a CT scan and the transfer could take over 4 hours?
Yeah, I mean, that's a tough question. Sometimes I would say I think about what you do in a rural setting, and I come up with that question. That question comes up here in the United States as well. Sometimes we have patients who are several hours away, and then weather, like there's a snowstorm, so you can't transition the patient to another center. So I would say in cases like this, you go to the basics. If the transfer can take over 4 hours, so number one, you won't know whether or not this patient has an ischemic stroke or a hemorrhagic stroke, so step one. So really, you really can't manipulate blood pressure one way or the other because you really don't know. Because for example, if there's an ischemic stroke and you try to drop it, then you're going to be stuck because you extend the stroke. So without knowledge of what a CAT scan is, you're going to have to go with basically maintaining cerebral perfusion. So that's going to be your air, that's going to be, oxygen, so optimizing oxygen, give them, set up an an IV, set up an IV, give them IV fluids like saline, so keep them well hydrated. And if they're hyperglycemic, and you've instantly treat the hyperglycemia, because also like hyperglycemia adds to basically reducing cerebral perfusion. Keep the head when you don't know, keep the head at 30 degrees. In general, if you could at least know that there was an ischemic stroke, you'd want to keep the head flat, but you really don't know. I really wouldn't even give aspirin, because you really don't know what kind of stroke it is. So you're really going to have to go with, maximizing oxygen, maximizing fluid status. And then, and if they have any signs of aspiration, so if you're starting to, basically have like lots of dysarthria, lots of dysphagia, lots of oral secretions, those are the patients that hopefully you can intubate, early. And at least protect their airway before you can send them, before the flight arrives for them. That being said, interestingly enough, there are there are ways in terms of like what we're using things like transcranial Doppler, in order to help estimate cerebral intracranial circulation, and transcranial Doppler, just like any kind of ultrasound, is bedside and readily available. So that's something that it would be a potential, but I actually don't know. I don't know if there's any radiologists on the line. What's the accessibility of transcranial Doppler here in the Bahamas? Because it really is cheap, and it's actually cheap and readily usable.
She says, thank you, Dr. Hepburn. Dr. Kerr also extends
Dr.
his
Kerr.
thoughts. Excellent presentation, Dr. Hepburn.
Yeah.
Okay, do we have,
Dr.
thank
Davis.
you,
Hi,
Dr.
Dr. Davis.
Hepburn. Very informative. Okay, do we have any other questions and or comments for Dr. Hepburn? Please remember to complete the feedback link. It has been posted in the chat. I will post it again there for you.
Can I get CME? I'm joking.
Sure you can.
Actually, I had a question. If from a colleague of mine's in the Caribbean wanted to know whether you guys record your CME sessions.
We do.
Okay. Perfect. All right. Well, my email is there. If you guys have any questions, interesting cases, neurology related, not necessarily stroke related, feel free to reach out. Always happy to help.
Thank you so much for that offer. I'm sure that we will definitely take advantage of that. So I see no further questions or comments in the chat. So with that, I would like to take this opportunity to again say a very special thank you, Dr. Hepburn, for taking time out of your very, very busy schedule to present a comprehensively well done talk to us. And I'm sure it has been very beneficial. I most certainly have learned a lot. And I'm looking forward to managing the next patient who presents post CVA. I'll also like to thank all of you, my colleagues, for joining us this morning for this CME. So we look forward to seeing you when next we meet, the second Wednesday and last Friday of every month. Have a great morning.
Bye-bye.
Bye.